Brilliant. Well, welcome everybody, and I hope this is going to be really helpful. Just to reiterate what Sarah's just said, we'd be very happy if you wanted to put any questions or comments in the chat. It would be really useful. I know some of my director colleagues are on the call, the webinar as well, and they may be able to answer some of the questions, but we'll look at the questions anyway and respond to them in a general mail out to practices next week. So I'm going to take us through the 2022-23 contract, and I'm going to touch on some of what I might call the what I might call certain uncertainties about the contract, and some of you have seen my letter from this morning which touches on some of those, and I will go into more detail about some of that as we go through the webinar. And in fact, the whole process of the 2022-23 contract has been a bit difficult, and I was going to come on to some of that as well. So I'll touch on some of the sort of political background that's going on as well. So this is kind of what I'm going to cover, and roughly in that order. And some of what we're going to talk about, there's already been update letters to practices across the LMC as well, which I hope has been helpful. So if we just seem to be in control of this, which is quite scary in some ways, but let's keep going. So basically, what we've got to remember is that this year is the fourth year of a deal that was negotiated, quite importantly, pre-pandemic, and we're in the fourth year of a 5-year multi-year deal. Now, when we negotiated a multi-year deal as GPC, there was quite a lot of positivity about that, because one of the real anxieties about the GP contract is it's become a sort of annual political football. And so what people were hoping is that by taking it out of annual discussions, there would be less political influence. Now, of course, no one could anticipate the pandemic, and also it hasn't turned out to be the case that there isn't annual discussions anyway. One of the real challenges is that those discussions have been very difficult this year, and NHS England and GPC could not reach an agreement on the contract, and I'm going to touch on why in a moment. Now, NHS England do not regard this as an imposition, which, if I may say so, is somewhat disingenuous of them, because some of what's going to be rolled out this year was indeed in the multi-year deal, but a lot of it has been negotiated subsequently, and therefore it's slightly disingenuous in my view that it's simply a continuation of what's pre-agreed, because there's quite a lot that hadn't been discussed in 1920. However, what had been pre-agreed, and I guess what their sort of stance is that the PCN DES and the overview of some of the specifications had been agreed 3 years ago, and the phased rollout had been agreed as part of the pandemic. So, you know, although I don't agree with the way they've phrased it, you can see where, if I can put it this way, you can see where they're coming from. Now, obviously, the pandemic and several other sort of unanticipated sort of events have led to a significant set of challenges for general practice. And what GPC tried to do in the autumn and January was to try and get NHS England to agree to changes which would help general practice in relation to these issues. And I've just listed some of the issues that were taken to NHS England, but obviously you'll all be aware about the cost of the National Insurance Levy from the 1st of April. You also may be aware that the minimum wage is going up. Obviously, it's critical sort of utility and cost of living pressures on our colleagues, which weren't foreseen at all. The QOF childhood immunisation targets, we've had a great deal of advice, support, and colleagues giving examples of how their QOF has been affected by just 1 or 2 children, and we know that in some cases it's been affected by you registering overseas refugees, which for where the immunisation status isn't available. And we also know that because of the pandemic, parents have been less keen to get children immunised, and the QOF indicators are sort of time specific. So we know all that, took all that to NHS England. We also said that just restarting QOF on the 1st of April is not a good idea. People haven't got the capacity, and there's still a huge overhang in terms of the impact of COVID. But along with the workload backlog, they weren't interested in making any specific arrangements for general practice. And that's why GPC said, well, this isn't something that we can support, and we're not going to support it. And NHS England went ahead. So that's why you can see why the LMC believes this is an imposition. In fact, a lot of what actually has been put into the contract reflects the PCN DES, and there's not a significant amount which affects other elements of the contract. And that's why in this presentation I'm going to sort of talk about the PCN DES quite a lot, but I'll do the first sort of initial discussion about the rest of the contract. Just to remind colleagues, unless it's me not being able to see, you're very welcome to put questions in the chat, and we will come back to those, but I'll let my directors sort of pick up some of them as well. So looking at the sort of basic practice level funding, and this is where obviously we need to distinguish between PCN level funding and practice level funding. The global sum uplifts are fixed each year in the multi-year deal, and the multi-year deal this year refers to a 2.5% global sum uplift. Now, actually, it's slightly more complicated than that, because as I'll mention a bit later, there's a little bit of unanticipated extra money gone into the global sum, and so the uplift is slightly higher than 2.5%. The global sum uplift includes an allowance of 2.1% for expenses, and the out-of-hours deduction remains at 4.75%, which, because the actual sum, global sum, has gone up, slightly increased. The QOF point value has gone up again, but obviously you'll be aware that that's because the average practice list size has continued to rise, and that's now sort of, well, it's 8,392, but I think the way we can anticipate things going, it's going to be 8,500 before long. Now, there will be a DDRB report this year, but it will only apply to salaried GPs and to the trainer's grant and appraiser fee. It won't apply to global sum because, as NHS England keeps saying, we're part of a multi-year deal, and this is what your negotiators agreed you would get. And that's why I said at the beginning there was quite a lot of enthusiasm for a multi-year deal when it was negotiated, and the mood music was that the annual contract rounds, which you'll all remember sort of getting an update on, they were very difficult because they could impose really quite challenging changes at short notice. But it doesn't allow adaptations to unforeseen circumstances such as we're now in. Now, one of the things that colleagues will be aware is that the DDRB may recommend an uplift that is higher than the expenses allowance within the global sum uplift, and that did happen last year, and there was no mitigation from NHS England. Now, this year the DHSC has recommended a 2% uplift, which is obviously just under the expenses. And I do understand that your expenses are not just in terms of staff, but also locums. But we are expecting a report in May, and we'll see what happens. There's been no indication at all from the DDRB what they're likely to be thinking about. So we'll have to wait and see on that one. So that's the sort of practice level finances, and colleagues will see that sort of filtering through. Now, in terms of the core contract changes, relatively limited. First of all, you'll recall that there was a requirement for 25% of appointments available for online booking. Now, that doesn't really fit with NHS England's sort of strategy for the future. So they've changed that to all appointments that do not require triage. Although obviously remember, because they're looking for people to be able to sort things out over the phone as well as person, so that there's not this digital gap, they've put that in the line as well. Now, I've had a lot of colleagues come back to me and say all my appointments require triage, so I'm not going to put any up online. I think what they're trying to get across here is that you've not got a fixed target now, and you've got flexibility to offer online booking. And you may say that there are appointments that you probably may not triage, such as sort of immunisation or screening appointments. If you do, then you don't have to, according to the contract, put them online. My feeling is that this gives more discretion to practices to decide what you want to do in terms of online booking, and therefore this is probably a productive change rather than being sort of fixed to 25% target. It is up to you, but you know, that's very clear. You can determine which appointments there are. Now, in terms of registration of patients, many of you have been registering patients digitally already, and that's going to be written into the regulations, which were obviously sort of based on paper. And what you may be interested to know is that there's a working group. Well, when I say working, NHS England are sort of at least participating in it, that is looking at a wider range of the way in which people can register to with your practice. So I'm going to kind of, I am going to look at the chat and come back to some of it in a minute. And if there's easy questions, I'm going to try and answer them, leave the difficult ones to directors. So in terms of that question about nursing appointments, absolutely. It's very clear from the guidance that you can choose which appointments you want to put online. And there's no target in the contract now. There's obviously an aspiration from NHS England that, you know, online is the way to go. But in terms of what you actually have to do, you can decide, as long as they don't require triage. I will come back to the immunisation issue. Now, they've also decided that you can keep the deceased patient electronic records, and you don't need to print them all out and send them back to PCSE. You can still return the Lloyd George notes, but you don't need to print out the you know, all the electronic records. Now, there's a quid pro quo to that, in that you are now going to take responsibility for deceased patient record access under access to medical records. Now, this is a bit of an uncertainty. PCSE's numbers suggest that this will be a very low number per practice, and therefore not a significant workload. We don't know how it's going to work out on an individual practice basis, but that's the quid pro quo against not having to print them all out and send them all back. Now, I mentioned at the beginning that there was a bit of continuing money in the global sum that's made the 2.5% uplift slightly higher. NHS England has decided to continue the 20 million, not per practice, unfortunately, per all practices in England, global sum supplement that is supposed, and I'm very much aware from what you've said, very much aware that it doesn't cover the workload, but it is a additional sum of money that's going into global sum to reflect the fact that you're still responsible for SARS. So those were the core contract. Now, obviously, vaccinations and immunisations are part of the core contract as well. That was one of the changes from last year, and there's just a few technical changes which are all based on the Joint Committee of Vaccination and Immunisation recommendations in terms of HPV. The MMR catch-up programme from last year is finishing, and the Fresher programme is also finishing, has finished now. You'll recall that there's a contractual requirement for practices to participate in one catch-up campaign each year. We don't know which catch-up patient campaign there's going to be this year. It's not been announced yet, so we're waiting to see. I just thought it might be helpful, because I've got vaccination and immunisations up there, to just sort of flag up again. It was one of the discussions. We have not been able to reach an agreement with NHS England about the QOF childhood vaccination targets, and I know this means that there are a lot of practices who haven't been able to achieve QOF points through no reason of their own. It's entirely due to inaccessibility of information or sort of parental hesitancy, despite all the work you do. Now, you're not able to exemption or personalised care adjust these points. Now, there are a couple of CCGs across England who have apparently made some mitigation. And what I've done is I've asked for the business cases of those CCGs, because if they are making mitigation, they will have looked for a business case. And I know there may be some CCG colleagues listening. I understand you'll need a business case if you're going to look at mitigation. We are working on this point because at the moment I've got no real evidence or guarantee that there's going to be a national solution to this for either QOF last year or QOF this year. So I'd very much like to suggest a way forward in which practices who can identify that this QOF gap has been caused by lack of information, understandably. Refugees is a very good example. Thanks very much. That's exactly the sort of circumstance in which NHS England very much wants patients, refugees, to be registered, as we all do, to get sort of good quality healthcare. But the unintended impact of that on your QOF achievement is something I think everyone can see is unfair. And that's the sort of mitigation I'd like to work to resolve. So it's exactly the point you're making there. Now, I haven't got any sort of progress to sort of say, unfortunately, at this point, but that's the way the LMC is working. Yeah. Right. Now then, the obesity and weight management enhanced service, that is being extended, if I can use that phrase, but the referral payment is being reduced, and the only change in the enhanced service is that patients must agree to the referral. Apparently there were some practices, I'm sure none in Surrey and Sussex, but there were some practices that were just searching their databases, identifying everybody with a qualifying BMI, and just referring them all to the weight management services. Now, I'm also aware, and I know there'll be some colleagues from Richmond here, there are a couple of areas that do not have level 2 local authority weight management services, which is a prerequisite for referral under this sort of enhanced service, and we are trying to work on that in those areas. But in vast majority of practices across the LMC Federation, you do have access to that service. Now, I would say this is optional, but the vast majority of practices signed up last year. Right, let me keep going. The comment that's being made about storage facility, I'll come back to that a bit later. Yeah. Now, QOF. Now, usually I can recall from previous presentations on contract changes that there were, pages of QOF changes and threshold adjustments, and I guess that was one of the reasons why a multi-year deal was attractive. There are no changes to QOF next year at all, except to the 2 quality improvement modules. Somebody with a sense of humour is decided that one of the modules is going to be called Optimising Access to General Practice, and obviously prescription drug dependency, a significant clinical issue, and so that's the other one for this year. Just to say that the quality improvement modules, the original plan was that they would change each year. Obviously, the last 2 years they've been the same because they couldn't be undertaken really in the first year, and as it turned out, difficult to undertake in the second year. They have now changed, and there's quite an extensive set of guidance about how you might want to sort of develop those ideas further. Okay, and usually the Royal College come out with some additional sort of background references or referrals, so that's sort of helpful. Right, now it's very interesting, isn't it, that I should be doing a contract update and reach less than halfway through the slides and now move on to just one part of the contract, the network contract DES. And I think it's really important from a sort of philosophical point of view to think that NHS England is focusing its attention on the PCN DES. And I'm going to come to some of the implications of that a bit later on. But in terms of what's changing in the contract for next year, the PCN DES is where there's significant changes. Now, I'm also conscious that the vast majority of people, colleagues listening, will be planning or are expecting to undertake the PCN DES next year. And I know that some of you are doing it because you're really enthusiastic about the opportunities of the DES, and some are doing it because it seems the easiest thing to do, and some are doing it because it's sort of the least worst option, if I can put it like that. And I think from an L&C perspective, we've been contacted by a number of practices who want to understand what would happen if people left the DES, but we also need to recognise that a lot of practices want to continue and make the most of the opportunities of the DES as well. And I suppose from our perspective, it's really important to provide support from all of those angles. And that's what I'm going to try and do as we discuss the next sort of part of this presentation, really. So there is an opt-out period for this DES, and that is until the end of April, the 30th of April. If you don't opt out, then you are required to stay in the DES for a further year unless the specification is amended in year when there's another opt-out period that applies. Now, last year there was an opt-out period in October. There's no reason to suppose, and I have to say my view is there will not be an opt-out period for 22-23 because the work that's been done on the specifications, and particularly the Enhanced Access Specification, that's already been written. So there's no reason for NHS England to amend the current specification. And just to remind colleagues, the COVID vaccination programme in heart service and the flu, what used to be the flu DES, but maybe a flu in heart service, that's all separate to the PCN DES. And so we haven't seen that contract yet, but that's going to be out for the autumn as well. By far the most significant change in the PCN DES this year is the Enhanced Access Specification. We knew that was coming, and basically what that does is it looks at the extended hours, which is already within the DES, and it looks at the CCG commissioned Improved Access Commission Service, which your CCGs have been commissioning in different ways, but they basically all got awarded £6 a head. Obviously in London it was a slightly top sliced after that, unfortunately, but that's the principle behind it, as you'll see in a moment. Now, if we look at PCN level finances, the ARRS funding is already fixed and will increase quite substantially, actually, for this next financial year into over £1 billion. Now, one part of me would say, what could practices do sharing out £1 billion of funding into Global Sun? I think the answer I would give myself is they could do a huge amount, but unfortunately that's not the way that NHS England is developing funding in general practice at the moment. Now, just to say that I'll come back to ARRS funding in a moment, but NHS England consider ARRS to be on track, but many LMCs have reported back that there are significant issues in terms of recruitment of ARRS staff, or at least perhaps, if I can rephrase that slightly, the priority ARRS staff that practices want to recruit first. Now, the investment and impact funding, that is going up. That was previously agreed to go up by 110 million this year, but there's a further increase because there's some new indicators in IIF, which I'll come to. Now, the IIF point value isn't, although IIF looks like QOF for PCNs, the IIF point value is a fixed amount of £200. The PCN CD funding remains the same, but there's a additional supplement last year, and that's been continued for this year with a discretionary use by the PCN as to how you actually spend that. Okay. The other sort of elements of the PCN DES in terms of network participation payment and the CCN, what's called the CCG baseline contribution, and also the what's called the bed fund premium, they all remain the same, so they're unchanged for this coming year. So if we look at that in a bit more detail, sorry, this is a slightly busy slide, but this is just looking at the PCN DES specifications other than the enhanced service specification. Now, early cancer diagnosis, this is being simplified actually, because even NHS England realised it was a bit sort of difficult to understand. There's been a sort of concern that prostate cancer referrals have been significantly lower and are not picking up during and sort of as we come out of the pandemic scenario, and so they've identified that as a sort of target without figures, but a target for work within PCNs. They also, without sort of giving any specific sort of targets or requirements, but certainly an expectation that colleagues will work towards this, have identified 3 other sort of plans. One is the improving uptake in cervical and bowel NHS screening programs and following up non-responders. Then the FIT testing for suspected colorectal cancer, which is an extremely sort of divisive and hot topic at the moment, because it clinically doesn't necessarily seem to be appropriate that workload is done in general practice. And also they're trying to flag up support for teledermatology, but making it clear that teledermatology is not part of the sort of requirement for dermatology referrals. So those are all things that you're being asked, and remember there's no additional funding within the PCN DES for this. This is just one of the specifications. You're being asked to sort of focus on that. In terms of the personalised care service, this does start this year, but the digitally enabled personalised care and support plan, which I think all of us are slightly sort of, well, perhaps some of you are much more sort of confident about that than me, but I think we're all slightly uncertain how that's actually going to work. So that's been put back for another year, suggesting that NHS England are slightly uncertain as well. And then the start date for the anticipated care specification, that has been deferred again, although again unfunded. You are expected to work with other providers in sort of contributing to how this is going to work next year. So that's the sort of work in terms of the other specifications apart from the enhanced service, which I will come back to separately. Now, in terms of the Investment and Impact Fund, we're making sort of progress on this because a lot of the indicators were announced in the autumn last year. There are 3 new indicators and they have been funded additionally. And these indicators I've listed there. So you'll see there's a link between what NHS England are hoping you will do with your fit testing referrals. So that's got a target specification, quite 2 sort of indicators relating to DOAC prescribing, and quite a challenging, or at least sort of controversial development in that for the first time really a identified named drug has been incorporated into your contract as a target for you to use first line DOAC. Now that has generated quite a lot of concern amongst your medicine management teams because it's, although it in a way they said to me, well, this isn't a surprise in that we thought this was what was going to happen, but it's a surprise that it actually has now finally happened. And you know, there's a specific reference to a named drug. We're kind of waiting to see, and I think a lot of your medicines management advice is still going to prioritise your clinical judgment. And the other significant sort of stumbling block with this is that a lot of these DOACs are initiated in secondary care, and it would appear, although who would believe it, it would appear that this wasn't joined up with secondary care clinical colleagues, and they weren't aware that this was going to be put into our contract. So it's a bit of a surprise to them. So there's a bit of work to do on that. And I guess we all need to think about how we feel about being contractually targeted to prescribe a particular named drug. There's also some threshold achievement targets been applied, which didn't have achievement targets up till now. So I think just going back to what Raja said there, this is one of the challenges, isn't it, about doing this really. We are sort of wondering how that's going to work as incentives to prescribe may change, or there may be other sort of clinical developments with other drugs as well. So I think what I wanted to flag up to you is not just the contractual sort of point here, but also the precedent and the sort of implications that colleagues may want to think about in terms of why this is happening. I'm not here to encourage you to ignore any particular targets, but I would remind colleagues that all of the IIF indicators are optional. So you may want as a CCG, as a PCN, to look at those targets collectively and decide that some of them may not be something you want to aim for. Now, obviously, patient access, really important sort of element here of what NHS England is trying to achieve. And that's why they've spent so much time wanting to develop a specification. And I'm going, because I know we've had a lot of queries, a huge number of queries really about this. I'm going to spend some of these slides to look at this particular specification. Now, when I started the webinar, I said that I would be touching on certain uncertainties, and unfortunately there are some uncertainties, and I've written out to all colleagues this morning to just say you need to think carefully about how you're going to deliver the enhanced access specification if you are. But if you don't want to deliver it, then there isn't any choice. You either have to withdraw from the PCN DES in its entirety, or you will be responsible for delivering the enhanced access specification. We did hope, and this was one of the negotiating points that was raised with NHS England, we hoped that it might be possible to subdivide the PCN DES so that the enhanced access could be divided from the other specifications, because the wording of the DES specification seemed to imply that that was possible. So far, GPC have not provided any indication that NHS England is willing to interpret things in that way. So the advice I'm currently giving colleagues is that the specification is indivisible. You either deliver all of it or you don't deliver any of it, which is a challenge for us all, I think. Now, the background to the enhanced access is that they are combining the extended hours, which was previously a standalone DES and then was put into the PCN DES in 2019-20. They're combining that with the CCG commissioned improved access. And those of you who like the maths will remember that the extended hours was £1.44. It's a £6 a head CCG commission service, and somewhere tuppence has appeared because the payment to PCNs is going to be £7.46. Now, don't all go away and wildly celebrate on that basis. It also creates the concept of network standard hours, which is 6:30 till 8 on weekdays and 9 till 5 on Saturdays. Now, I've had a lot of queries about what this means. Does it mean that, you know, if this is the thin end of the wedge, this could be giving back out of hours responsibilities? From a contractual perspective, it doesn't give back out of hours responsibilities, because this is a practice-based contract, a PCN delivered or subcontracted contract, and the out of hours service runs in parallel and independently, even if the services are being delivered from the same sites or coterminous with the sites, as I know in some places they are. So in one sense, no, it's nothing about sort of out of hours coming back after sort of 22 years, but in another, sorry, 18 years, but in another sense, yes, it does set, or it identifies periods of time outside the core contract where if you're signed up to the DES, you are responsible for delivering services. Now, within the PCN DES specification, there is some flexibility, because it does say that in discussion with your CCG, you may deliver some of your enhanced access. Outside these network standard hours. What it doesn't say, and the LMC's interpretation is that if you do deliver, for example, commuter clinics between 7 and 8 in the morning, we don't believe that that reduces your requirement to deliver services throughout the network standard hours as well. So you can't chop off a few of the network standard hours and deliver them in the early morning, as we used to do with the extended hours DES. So our reading, our interpretation of it at the moment is that you will still have to cover the network standard hours, even if you decide to deliver some of it at other times. Now, the other quite interesting sort of phrase in the DES specification is that you can deliver some of the enhanced access inside core hours. We don't know how the CCG is going to identify whether that's appropriate, how much of it would be delivered, what evidence you would need to provide to show that that's appropriate. Those are all things that we're expecting would be put in what's called the Enhanced Access Plan, which is what you're going to need to put together over the next, well, 5.5 months now. But those are the sort of options that are written into the DES specification, and I haven't got any feel really for how much flexibility there's going to be. So there is flexibility in the words of the DES specification in both of those points, but they both require CCG, and of course it won't be CCG after the 1st of July. It will be some other governance organisation in terms of making those decisions. And we don't know quite how the strategy from the ICS will meet the plans for enhanced access that PCNs will put forward. So I just wanted to flag up those. Points, but we need to sort of say to ourselves, these flexibilities are dependent on Commissioner approval. Now, I'm also going to say quite openly in this webinar that the CCGs across Surrey and Sussex have always worked really closely with the LMC on these contractual issues. So it's not that I'm expecting it not to be negotiable. I'm just saying that I don't know what the criteria will be that they will make decisions. One of the likely criteria is patient, one of the mentioned criteria will be patient demand or patient satisfaction with the sort of service that's being delivered. So that would be an important part of what you'd need to provide evidence for when you develop your plan. So that's next. Now, the next part of the specification describes a 60-minute per week appointment per 1,000 weighted patients in the PCN. That is based on, it's a different type of weighting. Some PCNs will benefit from that, and some PCNs will not, but they've decided to use the primary medical care weighting for CCGs to decide what your actual population is for the purposes of this specification. NHS England is very clear that their strategy here is to try and expand what is delivered in general practice beyond core hours. And what they want is for you to offer normal or routine general practice services during the period of the network standard hours. Now, that means that they're expecting you to offer both face-to-face appointments, remote appointments, GP appointments, nurse and ARRS colleague appointments, other healthcare professional appointments. Now, obviously, PCNs will have a different amount of flexibility into the type of appointments they can offer and the people that you will be able to sort of supply or recruit to deliver these services. But that's all got to go in the access plan. One of the other things that's been picked over semantically is, what does GP cover mean? Because the specification says that the GP cover has to be available during network standard hours, including undertaking consultations and supervision and oversight, presumably for other colleagues who are working at the same time. So we are waiting to see exactly what interpretation is. Does it mean that a GP has to be physically present throughout the entire network standard hours, which would be quite an ask, or does it mean that that supervision and oversight could be provided remotely, and so could some of the consultations? There's no specific target as the proportion of consultations that have to be face-to-face. The wording in the DES specification is that a reasonable number which meet patient expectations and also contribute to dealing with health inequalities. So those are the sort of criteria that I guess you need to think about when you're developing this access plan. In terms of the question that's just been asked, we don't think that it's very difficult. We've already asked for courier courier services to be expanded in relation to the phlebotomy locally commissioned service in some areas, and it's proved quite challenging to change or expand courier services. And clearly, if you haven't got courier services, you won't be offering phlebotomy appointments. So you need to have it set up, but that would be an excellent, in my opinion, point to make in terms of the access plan. And picking up one of the other questions, obviously, if the CCGs or commissioners wanted phlebotomy during the network standard hours, they would then have to support courier services, because that's not actually your responsibility to organise them. So it's very much a sort of it's all weaved together in terms of what you're going to be able to do. I'll move on to the next point. Now, the specification requests that there are pre-booked appointments within network standard hours, and they should be available up to 2 weeks in advance. But there's also the facility for NHS 111 to access what are called unused on-the-day slots, and the expectation is that NHS 111 will be able to use some of the appointment slots that are being offered in the network standard hours, and by implication that must mean that some of the slots won't. By implication, that must mean that not all the slots are pre-bookable, or at least they're not all filled up. So that again, we're going to have to see how that works. Obviously, we've got NHS 111 accessing our workbook through our contract at a 1 in 3,000 proportion to your list size. It doesn't say that you have to allocate slots to NHS 111 in any kind of proportion or number. It just says that if they're not used, then NHS 111 should be able to access them. So that's the way NHS 111's sort of integration into this is being described. You're also required to have a reminder system, which presumably will be text. I don't think it would be reasonable to be telephone, but it doesn't say. And you need to have a facility for patients to be able to cancel appointments as well. Obviously, there's some other references in the specification which refer to IT interoperability amongst the core network practices, where the sites are being delivered, where the service is being delivered. It says that there cannot be fewer than the number of sites that are currently delivered for CCG improved access, but that's not going to be a challenge, I think, because in most CCGs that's a relatively limited number, and if PCNs decide to subcontract this enhanced service, then it's likely that the number of sites will not fall below the number that are currently delivering improved access. Now, in terms of subcontracting this, obviously this is an option. Our reading of the specification is that it doesn't have to be all or nothing. You could subcontract some of the delivery of the service and keep some of it in-house. And obviously, that's something that you're going to need to discuss both as a PCN and also with any potential subcontractor. There's no flexibility locally in terms of the money. The PCN will receive £7.46 per weighted patient, and then you're going to have to, if you have negotiations with subcontractors, you're going to have to discuss with them how much it's going to cost. And obviously the idea is that if you are going to subcontract the service, then the enhanced access plan that you submit to the CCG in August, or by the end of July, will include the active sort of collaboration and discussion of the subcontractor as well, so that the CCG can be confident that subcontracting arrangement is going to work and it's going to deliver all the things that I've sort of described within the enhanced access specification as well. So it's going to have to be a collaborative plan that's sort of written with your subcontractor if you're planning to subcontract. and what proportion or all of the enhanced service is going to be subcontracted. Now, I've seen sort of a number of questions in the chat, which I've learned from experience that if you're presenting something, it's quite difficult. But just picking up some of the points that are being made, essentially, what NHS England want is for network standard hours to look like normal general practice, but you've got to get the staff to you've got to deploy the staff in order to deliver these services, and it may be very difficult to get staff to work what are effectively unsocial hours. You may say to me, well, we'll get some of it done inside core hours, but that depends on commissioner approval, and we don't know the criteria that they're going to use. My suspicion is that NHS England is not looking for in-hours delivery of the Enhanced Access Specification, except in very exceptional circumstances. And I think what they're focusing on is the delivery of services in the network standard hours, and that's what they're sort of looking for PCNs to take responsibility for. Now, if you do subcontract, you'll have a subcontracting agreement, but ultimately the responsibility for the service is you as the PCN and you as the core member practices. So that's the sort of scenario you've got. I'm just picking up that other question. No, we don't see. We don't think that these extended hours represent core hours in the sense that you need to have your own reception open or your phone, your phone's on or anything like that. So, I think it's fair to say that they're still distinguishing between delivering a specific service rather than making it look like an extension of core hours. All they want is that the appointments within those standard network hours are mimic the sort of appointments and care to as much as is possible that you can get from general practice in core hours, and that includes the variety of staff and the type of remote or face-to-face appointments that you can get. So I think that's what they're thinking, and I think that's what they want. They're not asking you to operate as a practice outside core hours. I could, if I was being mischievous, say at the moment, but to be fair, I don't think that's what they're trying to achieve. What I think they're trying to achieve is something different. I think they're trying to achieve a service that is being delivered by a PCN rather than by individual practices, and that's what I think their thinking is for. Now, if we go back to ARRS, as I said, quite a lot of money. Just think what you could do with it in global sum. Of course, we know why it's not in global sum, because NHS England think they have a very good idea as to what you would do with it if it was global sum. But I think that's unfair on us all. Now, NHS England believe that the ARRS recruitment is on track. And in fact, the statistics suggest that they're right in that the numbers are roughly on track. But what we do know is that the demand for certain personnel within the ARRS scheme is exceeds the supply, and also the major flaw within the scheme is that there's no provision for the management and oversight and appraisal type arrangements that go with having these additional staff, and that's been a huge stress because in many cases it's only GPs, colleagues who can deliver that role. And in terms of the burden on practice managers, that's the other issue, because although you might get GPs to do the clinical oversight, the sort of employment parts of deploying these staff often fall to practice manager colleagues. The other change for the ARRS this year has been an uplift in the number of whole-time mental health practitioners that you can get reimbursed for if you can get agreement with the local mental health trust or provider to recruit these and work out a sort of mutual joint plan. And I know from sort of feedback we've had that's been one of the sort of biggest challenges that that colleagues have had. Now, this is a bit more of the discussion that I've had already, and now there may be colleagues who think I've got no intention of leaving. You know, this bit is irrelevant. Julia, stop talking. And there may be colleagues who be thinking, well, actually, this is something I need to think about. I think what's interesting is that if we think through, it's obvious that NHS England are making the assumption that very few practices will leave the PCN DES because of the complexities that would arise if significant proportion of practices did. Now, obviously, I've already alluded to the opt-out, and a question that came up earlier I can answer. So basically, the way the opt-out works is that you have to opt out. If you don't opt out, then you're assumed to be participating in the PCN DES for the next financial year, 22-23. There will be another opt-out period in April 23, when you'll be able to make the same choice again, but you won't have the opportunity to opt out during the rest of the year. There, in my view, as I've already discussed, won't be, or it isn't likely, as far as I can see it, it isn't likely that there will be another in-year amendment to the PCN DES because they've done everything that they want to do for it now. So if you do want to opt out, you need to discuss this with your PCN CD, your other member practices, and then the way the PCN DES is, the specifications written, the LMC and the CCG have worked collaboratively, which is not a problem in terms of how to manage the situation if a practice does decide to opt out. Now, if you do opt out, then clearly you don't have to deliver the DES services. I mean, you can say, that's fine, I'm not going to deliver the DES service specification, I'm going to deliver my core contract, I'm going to do QOF, but I don't have to deliver, and I'm not going to deliver the DES specifications. So that's easy from that perspective. However, you still will have a duty of cooperation. Now, we have seen this in action because we have got a couple of practices that have not been participating in the PCN DES. So just to give a couple of examples, really, what that meant was that the non-participating practices had to give the times of when the extended hours appointments were and a number to ring so that patients could book the extended hours appointments that were being delivered on behalf of that practice by the rest of the PCN. And you might need to identify patients who would be suitable for the Enhanced Health and Care Home MDTs, for example, but you wouldn't be participating in those MDTs and you wouldn't have to manage the team that was delivering it. So there might be data sharing or data extraction duties that you'd have to undertake, but you wouldn't have to actually be responsible for the work that was being done. Now, what the CCG will have to do, and that's where you know, the discussion with the LMC comes in, the CCG has to ensure that if the practice list of the non-participating practice, those patients can still access the services that are being delivered by the PCN DES. And therefore, if you don't participate, your list will be allocated to a PCN that is delivering the PCN DES. Now, that discussion may be that your list will be allocated to the PCN that you've left, or it might be allocated to another PCN. You would be obviously know what was happening, be part of that discussion, but ultimately that decision wouldn't be yours. Okay, and then the surviving PCN would perhaps surviving is not the word I'm quite looking for there, but the continuing PCN would be responsible for delivering those services to your patient's population. Now, in a practical sense, some of the specifications that might be quite tricky for them to do, but if they needed information from you, you probably have to provide that information, but you wouldn't have to deliver the service. In terms of the financial implications, the only thing that directly goes to practices is the £1.76. So you would lose that straight away. That wouldn't be paid to you. But all the other PCN DES income goes to the PCN. So that is received directly by the PCN. Now, those of you who are thinking this through are thinking, well, okay then, so my list gets allocated to a PCN and they get the reimbursement associated with those number of patients. Unfortunately, it's not as simple as that, because those patients aren't registered with a core member practice, so they're not counted as far as the capitation payments that are made to the PCN. So it's down to the CCG to make arrangements for a PCN that's delivering those services to receive an equivalent sum of money as they would do if they were getting reimbursed. And that's quite a complicated ask for the CCG, but at least the financial streams are identified so that you can do that. That's what would happen in terms of the finances. Now, obviously, this is a tricky issue for practices to think about if they are going to withdraw. And I think the LMC's advice is that you need to, discuss it with colleagues in your PCN and your PCN CD and CCG early on. But it's an option for you if you wish to. Okay. Now, from an LMC perspective, we think you need to look at this balance quite closely, and I will make no bones about it. I think that the Enhanced Access Specification is quite a significant skewing of the workload implications for practices in relation to the PCN DES, whereas some of the other specifications were probably not creating a significant demand. It's clearly going to be a challenge for colleagues to identify staff who are willing to work and to sort of consistently work during the network contract hours. And we know how difficult it is to recruit in other areas of practice. So this is going to be a significant ask. And unfortunately, NHS England do see this, just as they saw the extended hours. This is supplemental. This is additional to what you're already providing during core hours. It's not seen as a quid pro quo where you can sort of deliver it in network standard hours but not deliver services. And as one of the comments has been made, you cannot sort of expect a service to just continue indefinitely without appropriate sort of resourcing. And what we're seeing in general practice is a depletion, an erosion of staff who are available to work. If you employ ARRS staff directly and you don't participate, then they will be tupied over to continuing PCNs. If you've got a PCN CD whose practice decides not to participate, they can't solely work at a core member practice. They'd need to work at a member practice as well in order to continue their role. I think one of the most interesting ways in which you can interpret the PCN DES is that you can still be a PCN member without being a core member practice, and that allows an element of local agreement in terms of delivering some services by agreement with the PCN, but not having to take responsibility for delivering all the specifications. So we've seen that happen with extended hours, for example. We've seen non-participating practices continue to deliver extended hours, and be reimbursed for that through the PCN, but not deliver other elements of the specification. Now, this webinar was designed to go on slightly after 2 o'clock, and I did want to just flag up a couple of other issues. So essentially, GPC, whilst not supporting industrial collective action, and colleagues will recall the indicative ballot in the autumn last year, there's no GPC England support for that, and therefore, by definition, no trade union protection for those kind of actions. But GPC has put out advice and options to practices looking at safe working. And what I've done is I've sent out specific LMC advice on 2 of those, which is practice list closure applications and contractual withdrawal from the PCN DES. The other issues are very much in your hands in terms of appointment times, because it's perfectly open to you to set your own appointment times as you wish. And there are more and more practices thinking that 10 minutes is not sort of rewarding or professionally feasible, and also thinking about unresourced workload that you continue to get from a great many sources, unfortunately, and saying no to that. And I will be supplementing the LMC's advice on unresourced workload transfer from secondary care. And finally, just a bit about what's going to happen next. And I saw a couple of questions in relation to that. Now, I think, you know, everyone listening to this, we've got to recognise that where we are now, when the new contract came out in 2004, there was a significant wave of optimism. The out-of-hours burden, which had become a significant burden, was lifted, and it looked as if, in terms of financial reward and managing workload, that we were going in the right direction. I think we all recognise that at the moment, in terms of GP recruitment, retention, our ability to provide safe care, and what we want or value from a rewarding professional career, that is not what our current contractual arrangements are providing for us. NHS England have said that they are quite happy to enter negotiations into what the contract might look like, but they won't do so until the end of the multi-year deal, with a 5-year multi-year deal. So that means that we have a 5th year of the multi-year deal next year, unless we take steps to say that we can't continue as we are, and that would involve some of the actions that were discussed last autumn in the indicative ballot. What does NHS England want? So there's a lot of speculation about this. Do NHS England want a salaried GP service? Do they want us to integrate with local trusts? Do they want a sort of super practice based on a PCN footprint, with a front door that isn't necessarily our reception? Is it an NHS 111 or an NHS app front door for patients so that they digitally access our services, except for the sort of minority of patients that won't do that? Or do they want a sort of tiered NHS private service where NHS commissioned provision of general practice is much more constrained, as it is in the dental contract? Now, I think the answer to that question is that actually they don't know. They don't feel satisfied with what they've got now, but they're not sure whether they could deliver the service that they've got now in any of those models politically in a sort of acceptable way, and in terms of retaining a workforce. And that's really, you know, that you could say to me, well, that makes it a complete mess. Or you could say to me, and I'd be glad for you to say to me, that actually might mean that NHS England might come round to the idea that actually what they've got now is the best model in delivering healthcare to a registered population. And I think there's still a significant sympathy for that view within NHS England as well. But unfortunately, we're sort of tied to the sort of multi-year deal and the PCN DES in terms of our negotiating at this point. So that's not really a contractual matter for this coming year. It was just that I wanted to flag up to colleagues that those are the sort of discussions that are probably going to appear again in the coming year. But I also would say to you that I think it's likely that NHS England's preferred position is to continue with the PCN DES and therefore the current multi-year deal for the full course of the 5 years. What they've said in terms of going forward is that they would like to continue the PCN model, but they're willing to negotiate on the core contract as well. So that's where we are, but there's been no further sort of detail. Now, obviously, there are some sort of, kites being flown. You saw the comments, surrounding the idea that the service should become salaried a couple of weeks ago, with Sajid Javid sort of putting a forward into that document. But I wouldn't want colleagues to think that that's a done deal or an inevitable sense of direction from NHS England, because the most efficient model in terms of money and value for money is the model we've got now. Right, I'm going to stop there. I think the last slide is just a picture of the 5 LMCs across the Confederation. I hope that's been helpful. I hope that's been interesting. Thanks very much to my colleagues for answering some of the questions in the chat, but we will look at those questions again. And this is going to be repeated, or possibly not repeated for you, but for colleagues who weren't able to join today, next week. And then as Sarah said at the beginning, a video of me, which I'm sure will not go down in history, will be available, and we'll choose which one is best. I won't make that choice. Be available on the LMC website. And as always, if anybody has any queries about anything that I've covered in this presentation, anything that you'd like to contact the LMC office for, please do, because we're here for, obviously the LMC is here for you in terms of helping you make the best of the contract we've got, and best professional advice we can provide. So look forward to face-to-face meetings in the future, but I know this has been a good vehicle for being able to speak to so many people. That's great. So I will finish, and I'll just we'll stay on, maybe not my photograph, maybe not my picture.